Welcome to the Healthcare Air Deep Dive Podcast. My name is Garth Holmes, and today we have Dr. Hudson Garrett joining us once again. Our theme for today's episode is the role of air quality in emergency preparedness. Welcome back, Dr. Garrett. And for our listeners joining us for the first time, could you tell us a bit about yourself and your background?
Sure. So my name's Hudson Garrett. I'm an adjunct assistant professor of medicine in the Division of Infectious Diseases at the University of Louisville School of Medicine.
Thank you for that introduction. So my first question for today is, how does air quality play a role in emergency preparedness?
Well, when you think of emergency preparedness, a lot of people are not even aware that it exists because it's a sort of behind the scenes activity. It's something that we do for continuous readiness. You walk into a hospital and there's an expectation that the staff in the emergency room are always ready for what might come through the door. And that's more emergency medicine, right? And that's the emergency department. But there's also this other group called emergency management that is really stacked on top of that are looking at things like surge capacity when we have a large influx of unexpected patients, whether that's with a natural disaster, which of course we've experienced a huge influx of here in the U.S., particularly in the last week, or a large amount of potentially respiratory infectious diseases, or something more sinister like a man-made event where we have a biological agent or something like Ebola as well. And so emergency management is really charged with protecting the staff, the visitors, as well as the patients and their families when they come in during these times of need. And so they think about everything from, fire evacuations to biohazardous response type situations to decontamination. But one of the critical things is to make sure that the utilities, which includes air and water, are also safe for us to continue to use so that we can provide continuity of care. And I'll tell you, going back to the pandemic, there were many lessons learned, much more than we can talk about in our short podcast today. But one of the things that really stuck out to me was we have always historically underappreciated the role of the air. And the air is very much like an IV. If you come into an acute care hospital, for the most part, you're likely to get an IV inserted. I'm not saying everyone, but most inpatients will receive an IV. Well, every single patient and every staff member is exposed to the air, right? Continuously, the entire time that you're there in the healthcare environment. And so it's really one of those utilities that we've taken for granted. And so contaminated air can play a huge role, not only in transmission of infectious diseases, but honestly also in transmission and really an occupational health conversation for transmission of potential harmful chemicals like VOCs, formaldehyde, and other things that might be coming into a building that are unexpected. And so this is where I think the emergency management meets infection control and meets emergency medicine, all at this sort of trifecta preparedness.
You talked, historically speaking, about, the underappreciation of the role of air, especially as everyone is exposed to it. Could you talk more about what role data plays in improving air quality and reducing infection risk?
Well, in healthcare and in medicine, we're always preaching practice evidence-based medicine, use evidence-based practice, and that is deeply rooted in data. And data can tell us good and bad. Sometimes I actually learn more from my failures and translating those into learnings and opportunities than I do my successes. And I'm sure many of our peers feel the same way. But data helps us to drive better decisions. It allows us to know if we swung the pendulum in a particular direction. Maybe we tried an intervention. Is it working? Is it not working? Do we need to give it a little bit more time? How is that intervention performing? So it's a critical element of continuous quality improvement, but it also tells us sort of the efficacy of what we're trying to do. And I think having access to data in real time is another critical element, especially when we're talking about air quality. I don't want to find out about an infection, 30 or 40 days after the patient is long gone. That is not a helpful activity. That is really not, frankly, infection control. That is something that is retrospective data review, compliance type activity. True infection control is stopping the infections as they're happening and doing so, as quickly as possible, so that future patients are not going to suffer that same fate. And that's really where the rubber meets the road there, is if we can directly intervene using a data-driven approach and say, our data is pointing out a potential issue, maybe here in the emergency department or here in the operating room. Let's go use that data to under sort of uncover, if you will, what might be going on, and then monitor it. And I think that's a key thing in healthcare. We are awesome at starting new initiatives. We're great at standing up committees. We're good at getting implementation and education. Where we really fall flat sometimes is building overall competency towards what the expectation of competency needs to look like and then monitoring. And so I think having access to data, especially for air quality monitoring, that's prospective versus just retrospective is a huge, huge, huge move that we absolutely need to make because, again, air is something that impacts every single person that's involved in the healthcare continuum of care.
Thank you for that answer. You mentioned continuous quality improvement and having data that is prospective versus just retrospective. Can you give us some practical tips on how clinicians can utilize air quality data to drive continuous quality improvement?
Sure. So, I mean, frankly, if we were having this conversation 10, 15 years ago, we would be having a completely different dialogue because the literature just had not evolved. It had really not morphed into the correlation that we know where air quality can impact infection rates. It can impact occupational health. Well, now we know this. And whether it's something as basic as, fumes from disinfectants, which we've seen in NIOSH data, or as advanced as, surgical site infections, because we've got a lot of VOCs and door openings. These are data points that we can absolutely use from a quality perspective to say, let's drive better clinical outcomes. Let's optimize our engineering. So, let's think about a perioperative environment for a second. And let's say that you've got 50 door openings in an hour. Well, any good perioperative clinician will say, what in the world is going on in that OR and why is the door getting opened 50 times, right? That is not an optimal workflow from a clinical perspective. That's going to put patients at risk, especially for more invasive procedures like joints or transplants or things like that that are going to be a little bit more high risk. Well, using that data to figure out what's the rationale as to why are so many people going in and out? Is there an operational inefficiency? Is there equipment that's not in the room that should be? Addressing those things, those intricacies can really then help us drive better outcomes. Well, let's go to the emergency department, a little bit less controllable, right? Because in the emergency department, these are clinicians that are highly skilled, folks that are prepared for anything that you bring through the front door. And so I have immense respect for the sort of aptitude that they have to maintain. That competency is wide. A good emergency room clinician can really deal with most anything. One of the challenges, though, is when they have patients that come in that can impact the other parts of the ER. And that's where infectious respiratory diseases come in as something, or a biocontaminant as an example. And so improving air quality and maintaining air quality, especially during times of high patient acuity and surges, can be tremendously helpful. We need data to really prove that what we're doing is working. And data is going to differ based off environment. So I may not be interested in the same level of data, for example, in maybe a general waiting room. But in a clinical area, I may really want to pull a little bit deeper into that data set and say, what's really going on? Am I seeing VOCs? What are the door openings? What's the temperature? What's the humidity? Other types of sensors that might be available in that technology. And those are all critical elements to help us continue to iterate and evolve as a healthcare system to protect patients and protect staff. And I think that's the key is air quality and air quality management through good continuous disinfection is a element of protecting patients and staff. It's no longer just patient safety, it's also healthcare safety, which includes our team members.
You talked about the impact in different parts of the ER. Where should air quality be monitored in procedural areas and the emergency department?
Sure. So, I mean, let's start with the front, right, where the patient enters. You have in almost every emergency department across the United States, you have large waiting rooms, right? And these waiting rooms are full of patients that are in need of care. And let's be very frank, wait times are not short, just due to the needs of care provider shortages, as well as other constraints on our healthcare system. So you may be sitting in that waiting room environment with a large group of people, right, in very close quarters. And those people are all sick, right? No one goes to the emergency department because they're well. They're there for some specific, typically emergent purpose for the most part. Well, that's really an incubation, area for, respiratory diseases and other transmissible infections. And so I think that's one of the first places that you have to start is how do you, have continuous air quality improvement in that environment and then monitor for it such. The second area that most patients go to is our triage area, right? Where we're going to do that immediate triage, determine the level of severity of the patient's complaint. Do we need to take them straight to the back? Can they go back to the waiting room? Do they need some basic tests? Well, that's a great area to be monitoring air quality because guess what? Every single patient goes through that area for assessment by a nurse. And so high throughput there, multiple patients going in there, tight quarters typically in these areas. The third area would be any of our procedural areas. So as we get to the back, think about places where maybe we have trauma rooms, we have procedure rooms where we might be doing emergency bronchoscopies. Those are your critical areas that are most likely going to have some type of aerosolization. And so we want to think about those as sort of our first tier. And another place that's also a top tier is our designated airborne isolation rooms. And so every emergency department is going to have at least one. But the nice thing is that there are portable technologies available that allow you to sort of move the technology back and forth as needed to create additional airborne isolation capabilities. Now, it's not going to create true negative pressure, but just the ability to protect staff and the patients in the room is going to be really critical in terms of the necessity there. But there's also new pending guidance that we expect to be released from CDC in the coming months from HICPAC, which is the Healthcare Infection Control Practices Advisory Committee that, I think proudly, talks more about the need for additional clarity around airborne isolation rooms and the different types of technologies that can be helpful, even above our traditionally used HEPA technologies. I'm excited to see this from HICPAC. I think this is needed guidance, especially post-pandemic, and it gives clinicians some clear-cut sort of instructions, right? Almost how to bake the cake. And it's always helpful, especially for hospitals, to have that recipe, if you will, for what could they do to really make sure they're as well prepared as possible, but also thinking strategically ahead of potential issues that might come up. Because again, especially in the emergency department, we have no idea what could come in the next hour. And that can be both exciting as well as a challenge. And, we can help, however, really do a better job of controlling air quality.
With everything that the ER is dealing with and not knowing what's coming next, can you speak more into the role of air quality in preventing the spread of infectious transmissible infections?
Yeah, so I mean, just in the last few weeks alone, we've seen this exact thing play out with measles, right? Measles is a highly transmissible, probably the most infectious agent out there that people could be exposed to, frankly, in terms of transmission. I mean, it's an airborne disease, right? It's got very small particles that can travel for long distances of time. If you ask leading epidemiologists, they say if we put 10 people in a room and one person's got measles, 9 people will get it. And so, its infectivity is tremendous. It's a very powerful disease. And so, I think about things like that. And then on the other side of the pendulum, I consider sort of our normal respiratory transmitted diseases like RSV and influenza and some of the other things that we have that float around continuously, but certainly have a seasonality peak to them. One of my close colleagues has flu right now, and it's March. And so even though we have seasonality peaks, we recognize that these things can pop in and out of healthcare regardless of when we think they will. And so, we have to consider air quality as a critical role of that. And particle size does matter. And so, whatever technologies or solutions we're using should be vetted for those different particle sizes, whether it's something smaller like measles, which is an airborne transmitted disease, or whether it's something that's a larger particle size that's more droplet transmitted like influenza or RSV. All of these have the potential to infect staff and other patients, but we want something that's going to be effective against all of that, especially in places like the emergency department where, let's be real, we only have limited number of beds, limited number of staff, and limited number of time that we have to engage with the patient. And so we have to be as expeditious as possible, but still maintain a high level of safety for our patients and our provider team. And I think that's where improving air quality can come in because these respiratory diseases are unpredictable. Sometimes we don't know what the patient has. And I think this is even more true for pediatric hospitals where the amount of different types of respiratory diseases is immense. They see a lot more diversity and specific types of things like rhinoviruses and adenoviruses than we might see in adult populations. And frankly, we also don't test for those things like pediatrics might do. And so there's going to be diversity across care environment too, where there might be even more sensitivity to those patient populations.
Thank you once again, Dr. Garrett, for joining us today and sharing so many valuable insights on the role of air quality in emergency preparedness.
It's my pleasure. Thanks so much for having me back.